All right, well, we're going to get started. Welcome, everyone, to today's live chat with Dr. Sheryl Lewin. Today is on Hemifacial Microsomia and the Porous Implant Ear Reconstruction process. Our special guest today is the one and only Dr. Sheryl Lewin. As you all know, she is the specialist on the PIER surgery. Go ahead, Dr. Lewin.
Thank you, Tiffany. I want to thank everybody for coming, and I do have to say that I realized that, well, this was Tiffany's brainchild to do these talks, and I have never given a talk specifically on hemifacial microsomia. So as I was putting it together, I was like getting more and more excited, and I had more and more stuff to say. I realized that I actually have a lot to say about this topic, so it may be a little long, but it's mostly just because I'm very passionate about this subject. And I hope I can teach you a little bit about why I feel that way about it today. So I'm gonna
Actually, you always go over, so we're all used to it.
Yeah, no, I know. Thanks a lot. Thanks. You know, the other reason you know it's special, Tiffany, is because literally first time I've straightened my hair over 2 months. I mean, I must be excited about it.
Okay. Everybody should feel very like
Okay, share, see, and play. All right, so here we go. Today we're going to talk about the surgical treatment of Microtia patients that have hemifacial microsomia. And first of all, to define it, the actual definition is a little different than what some of us think. So it's differences in the size and shape, facial structure between the right and left sides of your face. So simply put, we call that facial asymmetry. And most often it occurs just at a single individual within a family, not like a genetically inherited trait. Some, very rarely, mostly not. But the thing that most of us think about when we think about hemifacial microsomia is that it's only affecting one side of the face. But in reality, it turns out that in about 2/3 of the cases, both sides of the face have abnormalities. This is an important thing, I think, for parents to understand. And it's usually the abnormality is different on the one side than the other. So what we're going to do today is learn a little bit about this rather complicated condition, and you can tell it's complicated. These are all the names that people have given to this condition. But today, we're not going to worry about that. We're just going to use this most common acronym of HFM, or hemifacial microsomia. So in terms of treatment, there's sort of 4 things to think about with patients, and it depends on severity of the condition, and we'll go through all of that today. First, and at least in my practice, the first surgery that's done is typically the Microtia surgery. So repairing the ear. I only use the porous implant method we call PIER, for porous implant ear reconstruction, but we're going to talk a little bit today about MedPOR and rib cartilage, just to give you a little background on the differences. Some patients do really well with fat injection to the cheek and jaw. The reason I have that as a later time point is because that surgery requires taking a little bit of fat from your tummy and injecting it into the cheek and jaw area, and you have to have tummy fat to do that. So my little 4, 5, 6-year-olds often do not have enough fat in their abdomen to make a significant enough difference for their surgery. A lot of these kids will need dental and or orthodontic treatment because it's a condition that affects kind of all layers of the face, and the teeth are included. Certainly the one that we often think of is the jaw, which is involved. The most severe forms do require jaw surgery. This is often done, if possible, when you're a teenager, and that's because when you're 16, 17, 18, your jaw is done growing. However, as you'll see in more severe forms, kids can't always wait that long, and some really severe cases need to be done either in infancy or when you're a toddler, because it's affecting more than just the symmetry of your face. It affects breathing, and speech, can affect feeding, very critical. So we every single patient, and this is the way I treat these kids, every patient is like a unique problem. So you really have to look at all kinds of details in order to figure out the best solution. So why do I think ear surgery for patients with HFM is so special? Well, I believe it's the most challenging surgery I do. And I think, you know, I guess I realized when I did this talk how much thought I've put into this condition. You know, I've spent the last 15 years trying to get to a happy place with this treatment. And I feel like I have recently gotten there or am approaching getting there. But I also like it because I feel like it's the one area of what I do in ear reconstruction that really requires the most artistic vision. I have no doubt that when you're trying to take something that doesn't look the same on both sides and do everything humanly possible to make it look the same on both sides, the give and take of that interplay and that reconstruction is, to me, almost all about your vision, your ability to see things and understand them three-dimensionally and sculpturally. So the last reason I feel like it's special is if I look back on my career, okay, 15 years in, so maybe half of my career, I feel like the biggest contribution that I've made are these new 3D ear implants. And I've learned a lot just in the, almost 2 years, year and a half that I've been doing it. And one of the best things that come out, I'm happier with every ear reconstruction because of it, but I'm even more happy with the kids that have these really challenging anatomy problems. Okay, so this is an experiment. I tried this on my husband this morning, complete fail. So maybe this isn't gonna work with you guys, but I'm gonna just throw up these 4 adorable faces. They're all little boys with short hair that are approximately the same age. And the point of this little experiment is what is the eye drawn to? And all of these kids have slight asymmetries in their cheeks perhaps, and maybe it's just because they don't really, but their face is turned a little so they look slightly symmetric. But what I notice most is the, you know, unaffected ear on this little boy when all the other little boys have bilateral microtia. So to me, the point is with hemifacial is it's the asymmetry that your eye is kind of drawn to. And even if you're missing both ears, sometimes a lot of my parents of kids with bilateral microtia, like people don't necessarily like notice the ears so immediately, but then my kids that have, you know, one ear that's large and a little ear, they seem to maybe sense that it's a little more noticeable. Okay, so if that didn't work, I'm doing one other experiment. So if you saw these 3 faces, which one, you know, maybe makes you like think twice or look twice? And to me, it's the middle one, again, because you've got a big ear and a little ear. Now, these were taken over time. It's the same patient. It's my bilateral patient on the left who was born with no ears. And here in the middle is after we've done his first ear surgery, and that's after 1 operation. And then the last picture is after we've done a second operation to build his left ear on the right side of your screen. And that is, you know, maybe only a few weeks after surgery, so still settling. So I'm gonna take you through a series of my patients to illustrate from kind of like mild, moderate, severe, et cetera, what is the impact of hemifacial and what does it mean? And maybe you find that your child fits one of these categories and maybe that helps you a little bit, or at least that's my goal. So first we're gonna use this little guy who's what I would call mild hemifacial microsomia and go from top to bottom. What are the physical findings that a craniofacial surgeon would identify? So that's what I do when I'm examining these patients. And I notice that the eyeball and the orbit or the bone of the eye on the affected side is smaller and lower. So if you did a true horizontal through the unaffected side, you can see that eye sitting lower, and you have to tilt a few degrees down towards the microtia side or towards his little ear to get the eyes in the same plane. The next thing is all my patients have microtia, but not all patients with hemifacial necessarily have microtia. You can have a varying condition where it's really just affecting more the soft tissues of the lower face, and maybe the ear is normal or near normal or just slightly small. If we move down, you notice that the cheek is smaller. So if I just use the tricks of presenting to show you, here's the cheek on the affected side versus the unaffected side, it's very clear when you do that, that he has a smaller cheek. And of course, that's associated with a smaller jaw. And much like the eyes, if you do a true horizontal and then you try to line up the corners of his mouth, you'll see there is a slight angle upward towards the microtia ear. So eyes go down to the ear, teeth go up to the ear. And what we call this, it's actually a test for occlusal cant. We literally take a popsicle stick or a tongue depressor. We have a kid bite down on it. And if it's perfectly straight, good chance that they have a pretty equal jaw. But if it's tilting to the microtia ear, that's indication of a smaller jaw. So easy little test for you guys. Now, the last thing also relates to the jaw. And it's sort of like, because it's smaller, everything's getting pulled to that littler side. So the true chin point, which is starting at a vertical here, is always just a few degrees over. So one thing you really have to focus on when now you're looking at this child is, this is very mild. I've just pointed out all these details, but when you look at him, you just sit back and meet him, it is not something that's very striking or you would necessarily notice. And so as a surgeon, my recommendation for mild hemifacial is only to reconstruct the ear. I would not recommend for this guy fat injection. Maybe he needs braces, certainly not jaw surgery. So we do have to remember every single one of us is asymmetric. I am annoyed that every picture I take, my right eye is smaller than my left eye. It is what it is, you know, we've all got. So this little boy had surgery a couple years ago. So this is before the 3D stuff that I developed. But at that time I was using a one-piece implant. So that started in about 2017. And that's where I kind of gained control over getting symmetry in patients with hemifacial. And you can see this kid's only 4 and he's only had 1 surgery, but you look at his ear and it looks bigger. I just need people to understand that's of course intentional because he kind of has to like grow into this ear. We have to make all ears adult size. And then I can change the shape of the ear and size of the ear based on the age of the child and kind of what I see on the anatomy on the unaffected ear. So here he is before and after surgery. And 2 things I always think of when I see these young kids after surgery. The first is they always look older. Like parents are kind of shocked when they see 2 ears on their kid for the first time. And that day they look older than they did the previous day by a lot. He's 1 year older here, but he just somehow looks older to me. And then the other thing is that I find once you have an ear, if that ear is created properly, there is an illusion that the hemifacial is less obvious. So to me, he looks more symmetric in the picture with the ear, even apart from the fact that he has an ear. This is called a worm's eye view. We use this often to look at patients with hemifacial because it shows us bony deficiencies. So behind his little ear, the bone just indents a little bit, and after he's got an ear in place, you can't notice that anymore. But it's just helpful proving this is a mild case. And here's his other view. So now we're going to move to a more moderate patient with hemifacial. And there's something I want to teach you guys that has to do with parents that have talked to me when we have our phone consultation and said, you know, I noticed my child has a crooked smile and I've been told they have hemifacial microsomia. So the thing about that is, yes, there is an element of hemifacial that we can see from her smaller jaw. So we do our little popsicle trick and yeah, she's got a few degrees upward towards her little ear. But let's look at her bottom lip. That's actually quite a lot more pronounced angle than I would have expected because it should follow the angle of the teeth. So something else is going on here, and that is actually a nerve palsy. Nerve palsies are part of hemifacial microsomia syndromes. Not every kid has it. It can involve any nerve branch of what we call the facial nerve that moves your eyebrows up and down, helps you puff out your cheeks, helps you smile. And this one, marginal mandibular nerve, is a depressor of the lower lip. So what happens is when she smiles, you cannot see her teeth, her bottom teeth on the side of the nerve palsy, where you can see them on the unaffected side. So nerve palsies, there's a little nugget for you if you're watching. If your child has a nerve palsy that you can see on the face, either the eyebrow doesn't move up as high or like this little girl. And that little nugget is what makes me always want to check a palate. So what's the relationship? So it turns out when you have hemifacial microsomia, even on the inside, stuff nobody really talks about or tells you about, things are different and sizes of things are different and nerve relationships are different. So if you look, with the tongue depressor and you ask somebody, when the doctor says, stick out your tongue and say, ah, that's showing you the back of your palate. And so many times when I see nerve palsies, the back of the palate is asymmetric. And any parent can see this because if my little finger here, okay, that may look bad, but the middle finger here, if that's the uvula, okay, it moves asymmetrically up to the stronger side. It moves away from the microtia side. So the uvula, if it's heading from, instead of going straight up into the midline, when you say ah, if it's heading to the unaffected ear, that's an indication that palate is stronger. And why is that important? Why do we care? Because you need your palate to close to form proper speech. So there's all these connections with these patients. It's not simple. And I'm a plastic surgeon that makes ears, but I want to know, are my kids having trouble speaking? Do the parents know why? Is it because they have hearing loss? Maybe. Or is it because they have a nerve issue with their palate? Maybe. Or is it because they have an undiagnosed submucous cleft? Maybe. So that's all part of my examination. And it's been interesting that we have uncovered later than we have wanted to some issues with palates. So we're going to do a little exercise on this girl with moderate hemifacial to sort of see what is it that we're trying to reconstruct. So we bisect the middle of her face, and then using all of our little techniques, we can mirror her to be perfectly symmetric, something that never exists in nature, but just for the purposes of demonstration, this allows us to create an idea of this is what we may be after, and this is where we're starting. And there is a very large difference. So one of the things I want you to understand is this is not what we want. This is not our goal. Perfect symmetry in a patient with hemifacial microsomia doesn't work. The ear ends up too far backwards on the wrong angle of the skull. It's too, the angle doesn't work out right. And so there's these adjustments, something that I refer to as why you need artistic vision. There's no book, there's no paper, there's no teacher that can tell you. You just have to have years and years and years of taking care of these patients, and that's how you learn your craft. So for her, I just use a simple thing like, okay, let's say we want to match projection X on both sides. Here you can see what I did for her reconstruction. Now, she's a much older patient. So she was done with a much older technique. I actually had to use 3 implants for her, 1 for the base, 1 for the rim, and 1 for the skull. So I'll get into that a little bit more, but with all those crazy ideas, which was sort of new, we were able to get her projection okay and achieve part of that goal. And you can see the ear is closer to her eye and her nose, or to the center of her face, than the opposite ear. And it just has to be that way. Like, that's what works and makes kids look as symmetric as possible. Nobody looks at somebody from this view, so the fact that we can see it in this view doesn't really matter. The views that matter more is the frontal view, and we did okay on our frontal view. However, I don't have a long-term picture, and my only concern with this older technique is that ear base is not as stable, and the tendency is for it to fall down. I would love to see her again and see how she's done. And then when you look at this view, so she was too young to get fat injection, but if I knew her today, you know, perhaps I would offer her some fat injection to help with symmetry in this view.
Hey, Dr. Lewin, can I ask you a quick question?
Sure.
Somebody asked a question about the fat injections. Is it common that it can collapse or sink? They've seen that in some of the groups.
Oh, like the fat that is injected decrease? Is that what they're?
I believe
okay.
So.
So there's a lot of different techniques on fat injection. I'll tell you the basic rules. The basic rules are you have to inject more than you need to get the effect you want, because a certain amount of that fat is gonna die, more or less die, because it doesn't have enough of a blood supply. So over the last 5 to 10 years, a lot of plastic surgeons have really drilled down on fat injection. In my practice, I haven't done it as much for kids because it's a little complicated reason, but you usually need multiple injections to get enough of an effect. So usually it's, you know, 3 injections, let's say, to correct a moderate deformity. So maybe it's that they were not completed or they didn't do enough. But usually whatever lives 6 months or a year after your first injection, that should stay. My understanding is that should stay. Now there's one very odd caveat. So if you do this too young and the child goes through puberty and you've taken fat from the tummy and you've put it in the cheek, and then they gain a lot of weight in adolescence, the cheek will get potentially larger than the other side because it still thinks it's a tummy cell. It came from the abdomen and it gains weight like the abdomen. So I happen to be very conservative about doing fat injection. And, you know, so I'm probably not the expert for that, but the other reason I don't do it a lot is because if you need it, it's usually after I've operated on you and you're in some other state or country, and there's usually somebody local who can do the fat injection. So if you go to somebody good, I think usually after 3 treatments, potentially you might do better. There's a whole lot of technique to it. So that's about the best I can do.
One more just real quick question on fat injection, just since we're on it. This is from Maria. Would you do a fat injection if they are due to have a jaw distraction?
No, I wouldn't. Well, I guess it depends. I shouldn't really say that. It depends where they are. So if they're 10 years out and your surgeon believes they can make a nice improvement, you know, cosmetically, which will not be a full correction for somebody that needs jaw surgery, then yes, I think it's okay to do. If it's 2 years out, why not see how the jaw correction looks? And then you're not dealing with so many different things at the same time. And again, the older you are, although not as much fat survives with each fat injection as you know, between a kid and an adult, a kid actually usually, at least my recollection, don't quote me, is that kids' fat does better than adult fat. The newer techniques in fat injection may have evened that playing field, but you have so much more fat you can work with a bigger cheek and a bigger abdomen that you can do a lot more sculpting with fat. Okay, so we're gonna go to a more severe case of hemifacial microsomia. And there is one thing I wanna point out in this patient, because again, like I said, everybody's unique. You'll see at the tip of the arrow, there's a scar that goes from that arrow to his lip. And you notice the asymmetry of the mouth. Well, this child was born with a cleft. And although it's not the common cleft lip of the upper lip into the nose, this is a cleft lip that's seen between the upper and lower lips, and it heads towards the ear. So that lateral cleft is part of this whole syndrome. So again, more unique conditions, you know, with each and every child. Clearly you can see severe smaller jaw in this patient. So one thing to notice, as you get more severe, bisecting the face in half doesn't work anymore. So what happens is, if you draw a symmetric ear and you actually want to get the bisected face, you actually have to, well, let me see, it's coming here. You have to curve it, because the upper lip and then the lower lip and then the chin, you know, they're all compensated, but they're kind of being pulled towards the little ear. So in this patient, that white line is sort of what we're after, albeit not back as far as the opposite ear, but at least the goal is, in this frontal plane, you want the appearance of symmetry. So here's this patient after surgery, and thank you for sending these pictures all the way from Italy. My parents are so great. I'm such a stickler, but because one ear is in shadow and the other isn't, it's a little hard to assess symmetry. But I will tell you, this ear is a little lower and not quite as projecting as the other side. So I think I'm very happy with this reconstruction. I'm not sure I could have done any much better, but you still have to understand there will be some level of asymmetry to deal with. Now, that though, when you compare these two sides, that the hemifacial microsomia, like the cheek and jaw, it seems a little less severe than in the first picture. And there's a couple reasons for that, but part of it is so-called tricks of the trade, or trade secrets that I do with the goal of enlarging the cheek. And why is that important? It's not just important in this view. And it's hard to explain how I do it, but the reason it's important, you'll understand when you see. If we look at what we call the subunit of the cheek, bottom of the eye, corner of the mouth, front of the cheek to the ear, okay? And we're gonna compare that on this boy's two sides. You can see quite a big difference between the cheek subunit. But I did tell you before, we're not going for complete symmetry, because look, if we did complete symmetry, this ear would be positioned so far backwards and so far behind the microtia remnant, it just wouldn't look right. You'd have a microtia ear, the cheek is ended, you're now behind the microtia ear, and you're starting your new ear. So these are the little artistic things you have to figure out. So I alter the angle a little bit, I move it forward a little bit, I do my best to get them symmetric, and here is this child's result in that view. And here he is in a 3/4 view. Okay, we're moving swiftly along to a really hard case. And this child, I'm gonna sort of use as a way to teach you why I've had to push the envelope for my techniques. And I'll do my best to explain how it translates surgically. So here's her ear sitting on a pretty vertical base, much like, parents of these children. But here's the base that the little microtia ear is sitting on, and they do not look the same. You can see there's this pretty drastic downward angle, and remember that arrow because it plays an important role later in this discussion. When I analyze this and I want to build her an ear, I want an ear that looks as close as possible to this. So I'm thinking part of that ear has to have that same base. So what I was able to do is develop a way to do an ear and this customized base all in one single operation. So this child was so severe that she actually had to have a jaw distraction quite young in life. And so I don't have pictures of her before her jaw distraction, but clearly it affects both of her jaws. So here's her less affected side, and here is the more affected side. And you can see the ear would sit just above and lateral to that. So I'm having to deal with kind of all of these different things. So I'm going to break off and talk to you about comparing ear frameworks so you can understand why I don't believe this patient would have had, the result I would hope for with either a rib cartilage or a standard med-port ear reconstruction. So rib cartilage is always built as more of a two-dimensional framework. It's stacks of flat pieces of rib, you know, carved to look basically the shape of an ear, but they're always placed under skin, and so they can't be made to look three-dimensional right at the beginning. So slightly graphic video, close your eyes, and I'll tell you when it's over. But this is a wonderful surgeon in Canada, and here is her rib cartilage framework sitting upside down there. But it shows you the pocket that, you know, since I don't do this surgery anymore, I do not have a video like this, but she was so kind to let me borrow this. So you can see the rib is placed, you know, although beautifully carved, it's placed in a very tight skin envelope. That is the surgical technique, and there's not really a way around that. So here it is, just right on the operating room table at the beginning, you know, before she's even woken up. And you can see, in order to get 3 dimensions, you have to put another piece in there. It could be a piece of rib that has often not worked. So some people use a piece of porous implant, much like my implants are made out of. So this is not that doctor's patient. I don't know who did this surgery, but this is a girl who had a cartilage ear that was basically a failed ear reconstruction. But it does demonstrate an issue with rib cartilage that is well documented in the literature, very much accepted as one of the big problems is poor projection. Well, maybe you can overcome that with this technique if your base is pretty symmetric. But if you're like this little girl, really having issues with that base kind of in that funny angle, then you're really gonna have trouble with a rib trying to get symmetry. So a rib, this is just simulating that rib framework. It's a little more flat, it's not as three-dimensional, and it sits under like that. Your job is to swing that rib out this far. I mean, I think it would be extremely challenging and difficult to do. So what I have done for 10 years of my career, or a little more than 10, is I use a 2-piece framework. We called it MedPOR, that's what I used in the past. And you have to solder or melt these 2 pieces together. And I was quite happy with a lot of my ear reconstructions until, you know, I had enough years under my belt to sort of see there's got to be a better way, because these frameworks have a couple problems. One, a lifetime risk of fracture, which is not insignificant, because every year that goes by, that risk potentially increases with daily wear and tear, so to speak, on this ear. But if you have a fracture, even if it's mild and it doesn't even look bad, eventually you still need another surgery. So to me, if you could solve this problem, eliminating fracture from my practice, you know, that automatically saves kids from having to come back. Very worthwhile. So here's the MedPOR from different angles. And this was it's a belief, it's a theory. I cannot prove it, but after doing this long enough, I feel like I understand one of my problems, or one of the things that I was less satisfied with, was stability of this implant. And for far as I know, almost everybody in the world uses this kind of style of porous implant. And the problem is it's got a tiny ear print. So I want to say footprint, but the part of this implant that's actually touching your head is this itty bitty piece. So it seems stable when you put it in place on the body, but think about what happens when it's on somebody's head for many, many years. The tendency is that they can slip down, and then actually I have an error, sorry. It shouldn't be risk of fracture of sliding down. It's a risk of sliding down. It will be asymmetric, and if you had an ear canal made, a lot of these 2-piece MedPOR ears fall on top of that atresia repair, and that causes problems for the hearing. So to me, there was a real reason to eliminate these problems. So going back to our patient, we ended up recognizing that if we did a MedPOR for her, it would have slipped down, and it's almost impossible. It's like anti-gravity to get it to stay where I need it. There's no bone holding that up. So how do we solve this problem for her? Well, in my opinion, the best solution is going to be a custom designed 3D patient specific implant. So it turns out for almost 100% of my unilateral Microtia patients, whether they have hemifacial or they do not, they're getting this technology. I have embraced it like both feet jumped in, and I never want to go back to anything else because it's been a dramatic improvement in these patients. So this is what we refer to a 3D Lewin Ear Implant by Supor. Supor is like a brand name similar to MedPor, but they are both porous polyethylene. And if you have questions on the differences, we actually just did a recent Zoom on those implants and you can learn more about it. But the wonderful thing about this company, and to my knowledge, is the only company, and I'm the only surgeon doing this for just about every patient that walks through the door. So I'm able to build that part that she was missing in her bone into the ear implant. And this is a video that we made from her 3D scan, and we've designed a base. And so I want you to see, how that works as we rotate, and you can just appreciate how incredibly complex the ear shape is. And of course, there's this ginormous base, and it's incredibly stable. The footprint is huge. And what we can do is when we're in the operating room, I then can carve away this base right there when I'm with the patient, and I know exactly where it's going to go. And it has really been a game changer. And that's why you can tell I'm pretty passionate about, because I can get results I just could never, ever, ever get any other way. So literally this kid is 4 weeks after one operation. That is it. I couldn't have done this, at least not to this level, with any other technique. So I can't take 100% credit because that implant and the ability for me to design it however I want, that's really what gets credit. But I guess I get the credit for the coverage of the implant, which is probably equally critical, I'm sure. She likely will need a small revision, I believe. I don't know because she's not far enough out, but I always think sometimes that little earlobe needs a minor adjustment. So now I want to talk to you a little bit about atypical hemifacial, because sometimes I hear patients and they're like, my child doesn't really look like a lot of the other kids that I'm seeing online that say they have hemifacial microsomia. Like, I see differences in my child. So I have 2 patients very similar, and they present a very unique challenge. So one would think if you have a native canal on the side of the microtia, even if it's stenotic, that's a great thing. And maybe for hearing, you have better hearing than if you didn't have that native canal, maybe not. But if the canal is not in the right position, it makes ear reconstruction 10 times harder. So again, we're getting into the levels of technical challenge for the surgeon, that as a parent, you might not know. So her diagnosis is a low grade 2 microtia with oral stenosis. And what you notice is she has that atypical finding with the eye. So the eye on the microtia side is actually higher and larger. Here's the horizontal that shows you it's not following the rule, but it goes to that early definition of how it can affect both sides differently. But then the other thing to see is if we're looking at where her canal, unaffected canal is on this side, if we are trying to make her symmetric, this is where the canal would be. It is nowhere near where her canal exists. So those 2 centimeters, they may be 2 miles to me, like it's work. So that's when I go into a bag of tricks. I can't physically move it 2 centimeters, but I have little tricks, and a combination of all these little tricks kind of all mixed together helps me get closer to what we're trying to do. So here she is after surgery. She initially had a 2-piece implant done, and I think we were pretty happy with her ear reconstruction, but she got a fracture, and it was my patient. And so we took that wonderful opportunity to turn some bad news into some okay slightly positive news that, yes, you need another surgery, but we're going to do a 3D ear for you. So here she is after surgery. And you can see we were able to get her reasonably symmetric. Those native canals, they don't, when they're hemifacial and they're stenotic, they don't look exactly like a normal canal. Because you and I, you know, if you turn your head to the side, you cannot see the canal. You have to turn all the way backwards to see a canal. So for this kid, that's slightly different than her other side, but not very obvious. Here she is before and after. So this is another really challenging patient who has also a grade 2 microtia low, and he also has a lot of asymmetries to the skull bone. Now, in the most wonderful way, his dad is a radiologist, and he and I got together and we ordered some special studies, and he's like my first hemifacial patient that we did virtual surgery for. Again, I don't know if it's ever been done, but we modeled his entire head and both his ears, and then we can take away the microtia ear, and with software, we can turn the other ear around, put it on to these three-dimensional images from his CT scan, and we can design our implant. It's crazy cool. So that's what we did for this patient. But again, it's not perfect because this ear canal is still very low. And if you're matching the ear, you know, in what would be conceivably a completely symmetric area, the canal is not in the right place. Just like the last patient, it's much lower. So we have to make our little adjustments, do our little tricks, and do our best to get to a result that we can be happy with. So he is not quite as high as I might have wanted him, but sometimes what I do in the operating room, I do it with a towel, but I'll demonstrate for you. If you cover the face and then you cannot see the asymmetry, then you look and those two ears do look quite similar to each other. Not exactly perfect, but quite similar, and probably the best that I'm able to do, at least today. Here's his worm's eye view and a lateral view. This is the last patient we'll talk about. So thank you for hanging in there if you're still there. This is the same patient. I met him about a year before the picture on your right side. So this is when he was a little boy and then a teenager, and then he had jaw surgery done to help with the symmetry of his jaw. I thought they did a very beautiful job. And what he comes to me for is, at this point, he's never had an ear. I mean, there's no ear, there's no earlobe, there's no microtia. It's actually called Anotia. So this is what he looked like before his jaw distraction. You know, there's barely a bump, but there's no actual usable skin. So here he is right before surgery with me, and the bobby pins are holding his hair out of the way, but even under, you'll see, I'll show you, there's very fine hairs that you ultimately will, you know, are hair from your head. You can't use any skin that has hair from your scalp. It's a bad idea. You do not want a hairy ear. So the hairline, really critical. Like, nobody really taught me anything about a hairline in my training, but it is absolutely critical to understand nobody's hair goes straight up to their ear. And if you make an ear without making breathing room of hairless skin, the ear doesn't look right. So this patient, his hairline is very different. Many patients, when they get through puberty, do not have a true sideburn. So I'm trying to make a sideburn for this patient. And I think that's like an important thing to do for a male in particular. So here's his unaffected ear. Here's a symmetric version. Here's where we're going to position it. And if you look between the white dots and the upper blue, all that has hair. It all needs to be removed. So the next picture I'm warning you is in the operating room. So this patient is intubated, but here's where his ear belongs. There's that, all that area has been shaved where you see those purple marks. And this whole area is the breathing room required that I have to remove of hair-bearing skin. And you can see basically we're not left with any skin at all. So he's the first of two patients in my career that I have had to make an ear for him. Again, he was done with a one-piece implant, an earlier generation than the 3Ds, but one that already had an adjustable base. As you can see here, we can kick out the base so we get symmetry from his hemifacial. But he was done 100% with skin graft. So that's something important for hemifacial parents to understand. I can't use ear skin, which I'd love to, but we just don't have any in this case, or enough. Even from the other ear, it's not enough. So he's the only patient I've done 3 skin grafts for. We had to do 2 arms and a belly because he needed that much coverage. But here he is about 1 week after we did a tiny little earlobe adjustment, which was really kind of a little bump he had. We turned it into his earlobe. So you can see at the bottom of his earlobe, a tiny little black line. That's the itty bitty sutures that we put in. You can see because at 1 week, those sutures are still in place. So here he is after. Here's his worm's eye view. And for, you know, starting with no skin at all and no ear at all, I'm quite happy with how he has done. Voila. I think that is the end of my talk.
That was actually quicker than I expected. Nice work.
Oh, good. I'm glad. I'm trying not to bore everybody.
No.
Should I stop share?
Yeah, stop share, please. And we have a lot of great questions if you don't mind. This is a good question because it is kind of confusing, and I believe it was Vinithra. Sorry if I mispronounced your name. She asked, you know, with level of grade 3 microtia, how does that like correlate to the severity of hemifacial microsomia? Like, is there a correlation or no?
Generally speaking, microtia and hemifacial microsomia are actually thought by many to be part of the same spectrum. So if you have isolated microtia and no real apparent hemifacial microsomia, it's sort of thought that you're way, even if it's grade 3 or grade 2, whatever, it's way on this end of that spectrum. And then grade 3, and then hemifacial, and then it just keeps going. So grade 3 could be anything from no involvement with any other tissues or just the slightest tooth shift to, you know, pretty severe. So I don't think it's quite totally correlated that way. Like grade 4 would be the worst jaw. It doesn't work. There's a different scale that doctors use called the Omen scale that some people like to determine severity of hemifacial, but I don't think they're entirely correlated in the way that she's asking, I don't believe.
Okay. Another question from Thanos, I believe. Like, what is the order of surgery, ear surgery or jaw surgery first?
So it's really, I like to talk to jaw surgeons on patients that we're going to do ear surgery because it totally depends. Jaw surgeons may have preferences. So some jaw surgeons want to go first and others are fine to go later. And it really depends on, do they want to do the jaw surgery in teenage years? Then I'd say do the ear first. A lot of people in my practice, I guess I believe based on the age that kids come to me, would like to have their ear before they go to school, you know, with the hope of minimizing being different, I suppose. So we like to do the ear early, and I'm always, everybody that's my patient knows you have my cell phone. It's never changing, 24/7, 365. You can reach me. If you're in the doctor's office with your jaw surgeon, just call me. And if I can answer, I will, or we determine beforehand. And I'm happy to talk to all those docs. A lot of them don't understand porous implants, but it should not be in the way of what they have to do. Especially with today's awesome distraction osteogenesis techniques where, you know, everything's often internal and, you know, if they're not doing jaw surgery requiring external scars.
Okay. Another question here from Kaylee, I believe. Does ear surgery affect any future nerve graft palsy surgery? Sorry, nerve graft surgery.
It's a really good question. And the reason I hesitate is there's some newer techniques for smile surgeries. And I'm not 100% sure if like a temporalis muscle sling would be affected or could get in the way for that surgeon if the ear is already there. They use different anatomy. I'm using fascia, they're using other stuff. So that's a maybe, but in terms of what she said was nerve graft surgery, like if you're gonna bring something over and hook something else up to it, like a muscle from your thigh, for instance, like a gracilis free flap for nerve stimulating that free flap, then it should not be in the way. They can avoid the artery that's supplying the blood. And again, communication. I want to talk to that surgeon, you know, even if you're not my patient, if you're considering being my patient, I'm still willing to talk to anybody about, you know, it's all good because it educates them, but we don't want to have any undue risk with any of these families. And so we just have to go the extra mile.
Okay. Tracy is just wondering a question with a grade 2 ear. Would you use the little ear and the big ear? Like in the reconstructed ear?
Yes, absolutely. So again, that's part of the individual nature of the surgery. So it depends on so many like minute factors that until I'm examining you, I probably can't tell you how much of that ear, but whatever part of the little ear that is so-called normal in size and shape to the other side, or at least I can move it to become, you know, more normal in size and shape, that I can keep. And then the other parts, which is often, you know, that ear's folded over, that cartilage, even if you have a lot of that cartilage, I use all the skin, but the cartilage that can't be put into a normal position, that cannot be saved. Actually, it is saved. It's just not used in the ear. I actually save it. I call it banking. I bank it behind under where hair is because you may need it at some point. So we like to save it.
You did that for me. you banked for my son.
I did.
Does the type of hemifacial microsomia change with age? This is from Christina. For example, if a 2-year is considered to have mild HFM, can that change over time?
So some people believe that you, with growth, you can't catch up enough to improve. You don't get catch up growth, like a growth spurt that preferentially grows your jaw over your other jaw. But, and so the thought is that, yes, you know, it can get worse over time, but in reality, sometimes I feel like when kids are babies, you know, and they're different, you know, everything is different. The size of their ears are different when they're babies because they're huge relative to the head, and they don't have hair, and so things look different. But I feel like sometimes babies' hemifacial doesn't look as significant when they're toddlers. And then beyond that, my impression on my patients is if you're mild when I see you at 2, I'm still going to call you mild when I see you at 12 or 22.
Mm-hmm. Okay, I have another question. Do you want to maybe just briefly explain, although this might not totally be part of this live chat, but just quickly why this PIER might be the best option for those with prior ear reconstructions, such as a rib graft that, you know, perhaps has failed results?
Yes. So I try to be careful when I said like how much I love this, because it's, I think, one of the most challenging surgeries that I perform. I would say rib cartilage would be the other one. Or if, I guess I should say failed ear reconstructions, because it could be a failed med-pore ear reconstruction or a failed rib cartilage. So the success of that surgery depends on, do you have a flap? And if you, for some reason, all of your flap tissue is not adequate enough for me to use, PIER would not be an option. I don't find that to be the case very often though. Usually, even if we have to use 2 separate fascial flaps, we usually can find a way to make an ear with porous implant ear reconstruction. And I guess the benefit is we can save all your healthy skin, you know, so anything that doesn't have thick scars, we can save your earlobe. If you have a good tragus, we can save that. If you don't, we will make one for you. And so we recycle. So we recycle all the good and we remove whatever wasn't good. And so, you know, I have a lot of pictures of failed rib cartilage graft ears. And, you know, it's part of the reason why I've never been comfortable with that type of an ear reconstruction, because my goal is in one outpatient surgery, you get as close to a symmetric ear as possible. That's my goal with every patient now. Now, can I do it with every patient? Definitely not. Some patients will need adjustments. Usually that's an earlobe. At this stage in my career, that's mostly all I'm doing is earlobe or minor asymmetries. I hope that answered it. I don't know.
Another question. This may or may not be a question from a family that was on one of the first slides, but if you do have the older 2-piece implant and it should break, if you have, you know, whatever reason it should break, what is the process for replacing it with a 1-piece?
So I will say, when I came out with these 1-pieces and the 3Ds, I was like really cautious. I'm a conservative surgeon by nature. So like all my steps are done over years of time. And it's because like the goal is minimizing risks and complications. That's the name of the game for me. I'm obsessive about tracking results and specifically those kind of results. And what happened is, I used to say that I would only swap out a 2-piece for a 3D if there was a fracture. But I've come to see, and I wanted to show pictures, I just ran out of time, but I wanted to show pictures. There's a wonderful patient from Australia who had sort of a 2-piece, an interesting anatomy. He would have been perfect if we could have done a 3D, but we didn't have it at that time. And he had like quite a beautiful ear reconstruction. But what happened to him, and it's not a fracture, but because of that tiny ear print, those 2 pieces just tended to slip. Before I figured out, like, the cool thing about the 3Ds is nowhere before had the concept of sticking from underneath. So you put this nice, great, customized base onto this tissue. We never thought of that as something that the ear stuck to. We wrapped the ear, but it actually sticks, that base sticks now. So now, if a kid's got a 2-piece that's slipped down or they've got significant hemifacial, and we can do better by creating that, we can reuse everything. So I know which patient, because I know which picture, one of my faves, but if we swapped out his implant, it would probably cover about 75% of the new implant that may need to go up, may need to have some adjustments. But the other 25%, we just flip from the two that he's only had, well, no, he's a little more complicated. We did his little earlobe and stuff, but we can just flip back some fascia. Oh, my computer's falling. And then after we flip that fascia, we put a little skin graft in the back. But it's kind of cool because we can kind of do that whole reusing of all of his fascia and all of his skin. Once you've had that done, no matter what kind of implant's in there, if something new came along and maybe something we haven't discovered yet, and you wanted to have your ear implant changed, you can save all of that tissue and you just rewrap the new implant.
Okay. Another question from Sydney. Do you see a difference in the need for follow-up surgery or adjustments with HFM patients compared to those without?
Yes, I think it's fair to say yes. but I tell every patient that has more than mild hemifacial, every patient I talk to, expect 2 surgeries. And at that second surgery, you know, if we got to third base, we're going to make it all the way around the bases on that second surgery. What I think I'm striving for and hoping for is that's not happening to the same extent it did when I was using the old implants. So these new implants, if they're becoming more reliable and less need for manipulation, then there's less follow-up. So yeah, but I'm annoyingly obsessive on follow-up because I make you keep in touch with me. I mean, I'd be happy if you kept in touch forever, but that's probably asking a lot. But you know, I follow you closely for 3 months, very closely, and then pretty closely to 6 months, and then I want yearly pictures, at least at the 1 year time point. And then you always come back to me if anything happens. We just can take care of it almost all long distance.
Okay, here's a question from Nancy and Miles. Can you explain why lower set more to the front ear would need 2 surgeries? I'm trying to visualize it.
Yes, I can. It would be easier if I had that in my talk, but it just got too long. But the hemifacial microtia remnant is often too far forward on the face and too high, sometimes too low. Like a grade 2 might be too low, but too high often. So that's true of almost all microtia patients, or your average microtia patient, and we typically bring it back and down. But if you have hemifacial, sometimes that earlobe is dependent on the skin that's connecting it to the cheek. So I can't just pick it up and put it where I want. So it's always the earlobe that requires additional surgery, because if it can't reach the right place, you're not going to get the symmetry that we want. So that's why. I hope that makes sense.
Okay, one question here from Veronica. What do you think about using a scalp flap thin enough to get rid of the hair papilla?
So maybe she's referring to a scalp skin graft. That would be my suspicion. So I started doing that many years ago. There is a clear advantage to the surgeon. It is very quick. There's no donor site to remove. We take it so thin and pull out all the hairs, and you'd have this beautiful, huge piece of skin, and you could cover the entire ear with that if you wanted to. So it seemed like such a great thing at that time. I was pretty young attending, and just like so many things, over time, that skin never looks as good as full thickness skin graft. It's never the right color. Scalp skin is nothing like ear skin. Like, all these little tiny details matter. It wrinkles, and then it's not happy on the back. It was happier on the front. And there's just a whole host of reasons why I decided, you know, it's definitely more work for me, more time for me in the OR, but you know, in the end, I'm going to do what I think is in that patient's best interest, and it's the interest. Anybody that knows me, I'm not about getting out of the OR quick. That would be the last thing I could be accused of. But I just feel like the time that's spent on that first operation, whatever amount of time that is, it's critical. You're building a sculpture, and your first time is your best chance to get as far as you can.
Okay, we have some questions about the earlobe surgeries. Mary wants to know, does that mean the patient doesn't need to be put under? Could it be local anesthetic only?
If you were old enough, that is possible. If that's all that you've needed. I've done it under local, but like, I need you really still for me to, you know, go back and forth and check symmetry and do everything I need to do. So it kind of has to be kind of an adult. The anesthetic part, albeit annoying, like if I was getting a second stage, put me under. It is, we just did a second stage for an earlobe on a patient from New Jersey. It was the first patient that we did coming back to work last week. And it ended up like being harder than I expected. And I spent, an hour and a half adjusting this earlobe. Super happy at the end, but I kind of like in a child the freedom to take my time. I really do. He did super great after surgery. So like your experience after that tiny operation is not at all the same as a bigger operation, I would say.
Okay. I have a question from Kaylee. How long apart are the two surgeries, moving the ear and ear reconstruction?
So maybe she's referring, I didn't really get into it, but there are a few kids whose ear, if it's like kind of on the cheek, but it's got a lot of good skin, but it's really far away. I do a procedure called waltzing the earlobe. I don't know if I made that up, but it kind of came from a historical reference of olden times of plastic surgery. But you take that cheek earlobe remnant, which is really kind of your little ear, and you waltz it backwards. But again, the problem with these earlobes, you want to save the tissue, but the only way to save the tissue is to keep it intact to the body. But what's so cool about waltzing is once you put it back closer to where it needs to be, you can waltz it a second time and get that cheek to become an earlobe. So that's the one case where an earlobe surgery is done first. If it's done after, which is most cases because it's much more modest than that, it could be anywhere from 3 to usually closer to 6 months out. I like 6 months because it's things are pretty much done healing for the most part, but they're not going to change dramatically, so I know what I'm doing.
Okay, we'll just take one last question since we're running out of time. But as far as the second surgery, does it require the same amount of aftercare, and do you wear a ear cup?
Oh, no. No, this little guy from New Jersey, he didn't even have a cup except maybe, no, he didn't have a cup even. We just put some tape and gauze, and they just have to wash it. It's really pretty easy.
Okay.
It's quick. They were so bummed because they were like, they knew that the surgery was minimal. And they were like, oh, we'll go to Disneyland. We'll bring the whole family. Yeah, they didn't quite get that opportunity yet. But it'll happen someday. We'll get there, you guys.
Well, good. Well, I really appreciate everybody's questions. There were a ton. I'm sorry if we didn't get to a few. I know I kept referencing in the chat room all these live chats we've had. But they are recorded, they are posted to our website, they're on YouTube, and they are super informative. It's obviously the fresh new information. So it's all up to date and current, but you can email me at info@lewinmd.com how you registered for this, and I'm happy to send you the link and even try and direct you within the live chat where that information is answered. We do have some live chats coming up. We have genetics for Microtia, and then we have the PIER risks. So a lot of you guys were asking about some of the risks, and Dr. Lewin will be addressing that directly. And finally, yes, she is doing Skype and telephone consults, during this time when she's not in surgery. So you can contact the info and we can get you sent over to our awesome patient care coordinators who can schedule that for you. So would like to thank you all for joining us. It's so fun to see all these kids who are on here today. They were so patient and well behaved. Hi, James.
Oh, I can't see.
Hi.
Oh, there they are. James, how are you? Hi. Oh, hi, Amy.
Hi.
So I don't know how to mute you again, Amy.
Hi, Linda. I see you.
Yeah. Oh my gosh, you see so many. There's.
I'm gonna see you pretty soon, buddy. I see your ear.
I see Katie's
Oh,
little one. Hi,
Miles.
hi, Katie's little one. You're cute. I've been watching you for a while.
This is Bennett. This is
Hi,
Bennett.
You're adorable. Oh, he's so tiny. Oh, buddy.
Super
Oh,
cute.
so he'd be a good one potentially to do that little waltzing earlobe. A really good one. And actually, I should put you in touch with James's mom, Amy, who's also watching because James, didn't we do that to James' ear? Yeah. Okay, Tiffany will hook you mamas up.
We're totally in touch. We're in touch. Thanks
Okay.
to the internet. Thanks to support groups. And
Oh, okay.
pretty awesome.
I'm behind the times here.
Do you want to explain? Hey, James.
That way.
You want to show everybody your big ear?
But
I don't want to get waltzed up.
you fixed his cleft,
Right.
and that's when you did his. You moved his flap. It was about right here, and you moved it back there, and then you did that. Good.
Yes, I know.
Awesome. Well, thank you, everyone. Reach out to our office if you have more questions, and we hope to see you at future live chats. See you later.
Everybody.
All right.
Bye.
Thank you.
Take care.